Okay, good morning, everybody. Welcome. Thank you so much for joining us. I'm Kristen Casado, Director of Communications for the Connecticut chapter of the Alzheimer's Association. We have a great presentation for you this morning. Very important information. Culturally responsive dementia care at the end of life. We're talking about care at the end of life and how it differs in various cultures. And as we learn more about what this end of life process looks like, the cultural differences, the needs, the desires, the wants at the end of life, we will all be able to help more people. Just to let you know, we are having you all be muted with your video and your audio. Of course, if you have any questions throughout this presentation, please put it in the Q&A section and the chat section at the bottom there of your screen. We will address them after our speaker is finished this morning. I want to do a special thank you to Florence Johnson for bringing our speaker to us. It's Dr. Sheria Robinson Lane, and she'll be speaking in just a moment. But first, I'm pleased to introduce Chris Hortwell to you, who is with the Connecticut chapter of the Alzheimer's Association. He is in charge of outreach and education in the southeastern part of the state. Chris, I'll hand it over to you.
Thank you very much. And hello to everybody that's out there. And thank you for joining us today. We have a great program in store and some amazing guest speakers, as Kristen said. Today's seminar, Culturally Responsive Dementia Care at the End of Life, is a continuation of the association's mission to provide socially diverse supports and services to everyone in our community. And if you are interested in learning more about the association's continued diversity initiative, you can feel free to contact us, and we will have our helpline at the very end of this program today, and we will also have it in the chat box as well. So with that said, I'd love to get us started, and I would love to introduce Florence Johnson. Now, Florence Johnson is a registered nurse with over 25 years of experience in healthcare. She has a dual master's degree in healthcare administration and in nursing from the University of Phoenix, and a Bachelor of Science in nursing from the University of Connecticut. Ms. Johnson also holds Lean Six Sigma Green Belt certification. Her experience includes home care, quality improvement, and consulting. She spent the past 10 years working with nursing homes on safe care transitions and improving dementia care in the state of Connecticut. She has co-authored several published research studies on dementia care with UMass School of Medicine. She is pursuing her PhD at the University of Michigan, conducting research on how resources utilization to decrease stress promotes self-care and improve quality of life among Black informal caregivers of older adults with dementia living in the community. I'd like to introduce Florence Johnson.
Good morning. Thank you, Chris, and thank you for the opportunity to introduce Dr. Sheria Robinson Lane, who's our presenter today. She's an assistant professor of nursing at University of Michigan in the Department of Systems, Population, and Leadership. Dr. Robinson Lane has a clinical practice history in both long-term care and hospice. Her expertise is in advanced illness management, long-term care, and nursing administration. She has focused her career on care and support of older adults with cognitive and functional disabilities. To this end, she has developed and presented numerous presentations and publications on effective nursing practice and the care and system management of older adults. Dr. Robinson Lane's research addresses the ways that older adults adapt to changes in health, and particularly how health behaviors affect health outcomes. Her current work is focused on reducing health disparities for minority older adults and with cognitive impairments and their informal caregivers. Dr. Robinson Lane completed her PhD in nursing at Wayne State University and a postdoctoral advanced rehabilitation research training fellowship at the University of Michigan Medical School. And on top of all of this greatness, she's also my academic mentor. Welcome, Dr. Robinson Lane.
Good morning, and thank you so much, Florence, and thank you all for being here this morning as we um, really have a conversation about culture. That's really going to be the focus of our conversation today. Let's see here. I don't have any particular disclosures about the information or content that we're sharing. I work with a lot of different groups, but I don't get any particular benefit by sharing the information today. As Florence noted, I've been in gerontology and in hospice care and long-term care for a very long time. Some time ago, the Journal of Hospice and Palliative Nurses featured hospice nurses amongst us. And so I had the opportunity to participate in that issue. And it's really a joy because hospice in particular has always been at the heart of the work that I do. I consider myself to be a geriatric nurse and a gerontologist, and anybody that works in the care and service of older adults maybe should want to be sure that that also includes some education and support for people at end of life as well, because that's just one of the natural parts of the trajectory that we can anticipate. And so I really enjoyed that piece of my work and continue to contribute to end-of-life care practices, both clinically, mostly from a consultant space at this time, also within research and supporting students interested in these areas of care, and certainly continuing to work with families as they make the challenging decisions about whether to enter hospice care or how to support people who cure is no longer an option. And so as we call palliative care is what you get when there's no cure for what you got. And so I'm really happy to be able to contribute to these continuing conversations. One of the things that's really important as we discuss things, if you will, over the next hour, and we'll have some time afterwards to have some conversation between us and answer some questions. But one of the things that's really important as we think about culture and how we interact and engage with one another and how to provide excellent care and to get people to what some might call a good death is really having a basic understanding of how stress affects individuals. And so one of the ways in which I sort of think about stress is within this particular framework by someone named Callista Roy, who of course is a nurse, because I'm a nurse and so I'm seriously biased. And so what Roy says is that when we deal with stress from the environment, and the environment could be the space around you, or it could be your internal environment. So it could just be, you know, your body and how your body is managing stress. Let's see. Let me go and reshare that. There we are. And so what Roy says is that there are three major ways in which we deal with stress. You can have or different types of stressors, I should say. One is a focal stressor, another is contextual, and then the last is residual. And so if you think about a focal stimuli, this is the time of year where if you celebrate the holidays and maybe you decorate your house, this is a good time of year where you start thinking about when's the best time to put some lights up or put some decorations up and maybe do some last minute cleaning that I probably should have did last month, but haven't gotten to. So we've got some warm days coming up. And so you pull out your ladder and you get up there knowing maybe you have absolutely no business getting on top of the roof. You get up there and then you fall and break a leg. Your focal stress or focal stimuli is that broken leg. You're not thinking about the fact that like maybe some lights are half strung or that you look a little nuts and people might look at you. The only thing that you're concerned about at that given point in time is the pain in the leg that you broke when you fell off of that ladder. And so that's your focal stressor or focal stimuli. Maybe when you fell because you're too old, you shouldn't have been on the ladder to begin with, you peed a little bit. So you also peed on yourself. That is a contextual stimuli or a contextual stressor, something that is problematic, but it's not the main thing that you're concerned with. So if a neighbor comes by and like, oh my God, are you okay? You're not going to be like, yeah, I peed on myself, right? That's in the background, not important. What's mostly important is, I think I broke my leg. And that's what you're going to focus on. Everything else you deal with when you get that first thing, that focal stimuli managed. And so what that means is that when people are going through particularly stressful situations, it's hard for them to manage all of the other things that can be really challenging in their life. So if you have somebody who is dealing with a chronic end-stage disease, and that person, they're trying to figure out whether or not how long this person is going to be alive, what treatments they still need, is there anything that we can do? It's really hard for them to focus on work, home life, relationships, finances, all of these other things that can be significant and really impact quality of life for individuals. But that maybe not be the primary concern until maybe one of those background concerns take over. So when your job becomes maybe at risk because you're missing too much work and maybe don't know the right processes to complete, a leave, then that becomes the focal thing that you have to focus on for a moment, and everything else sort of moves into the context. Residual stress is something that's really interesting, because the way that residual stress is described is if you think about what residual is in general, residual is that nasty stuff at the bottom of your cup that you don't know is there until you got done drinking, right? You think the cup is clean, and then you have a nice big drink, and then you look and there's something in there and you're like, oh, it's the stuff that's left over. And so interestingly, with residual stress, because we don't know it's there until it kind of smacks us in the face. And so, for example, I'm a part of a lot of different groups. And one of the ways that these groups communicate is through emails and like message boards. And so sometimes late at night, they'll send messages back and forth. Most of them are supposed to be related to the organization, like assistance with committees and who can help with this, or updates from different people. But every now and then, like random chain letter sorts of things will pop up on that board. And so at one point, I was up working late, as I usually do, and I saw a message that said something like, if you want to prevent, or not prevent, it said to cure cancer, you should drink water on an empty stomach first thing in the morning, and then you should eat like vegetables. It was something sort of like nothing bad, but also nothing very accurate. So being the diligent nurse that I am, I promptly responded and said, well, that's not quite accurate. Like, those are all things that are very good for you, but it's not necessarily going to cure cancer. Those are some great ideas. Here's some other tips of things that you can do that are, healthy for you and may be helpful in preventing cancer, perhaps. And so I thought that was the end of it, but I guess the person on the other end was a bit offended. And so they responded and said, how do you know? You're not even a real nurse. You're a paperwork nurse. And I said, paperwork? And I was immediately angry. And I had to stop and think about it and say, why are you so mad? Because the paperwork part didn't really bother me. It was the response to the engagement. And as I started to think about it a little bit more, one of the things that came to mind is I immediately thought of my aunt. I have an aunt named Gloria. And this particular aunt was an herbalist. She used to carry these cards in her purse that looked like trading cards, but upon closer inspection, they were actually cards of people who had their colon cleansed, and showed like how fantastic they looked after they had this particular procedure done. She had cures and potions for everything you could think about. She could tell you what vitamin, what supplement, and what herb was good for you. And she was someone who often said that you should always drink water first thing when you wake up. It should be room temperature on an empty stomach. She also spoke about eating fruits and vegetables. And so for me, when someone was relaying information of something that was very personal and something that wasn't quite accurate, and then to take it a step further, I've also have other family members, particularly my grandmother, who also subscribed to many of the same things, but she still had cancer. And I also had another aunt that still had cancer, and she still died from cancer despite having these so-called cures in place. And so for me, it was very personal. It was rooted in some of the ways in which I was raised that then affect the way in which I responded to someone that I didn't even realize. And so for me, my residual stressor was this person's inadequate understanding of something that I sort of grew up with. And that's the way that residual stressors and stress really sorts of affects all of us. It often is culturally rooted. It has to do with the ways in which we were raised. And so we don't think about how the ways in which we were raised were very different from other individuals. It's just the way that it is. And so whenever you get that, like you get very angry, you meet somebody, you just can't stand them and you don't really have a reason for not liking them. You just like, oh, I just don't like, I can't put my finger on it, but something's not right. Oftentimes it's culturally rooted. Something about that person either reminds you of something that is from your history or background, or a way that you were raised that was taught that something was different about that individual. And so culture is really central in providing culturally responsive care and thinking about how we interact and engage with individuals and how we communicate. As you can see from this pictorial display here, these are a lot of the different components that make up culture. It's our traditions. It could be geography, how closely you are in proximity to somebody, so you have shared histories with those individuals. It has to do with the language that you speak. In fact, we group groups of people together oftentimes by language. So when we think about racial and ethnic groups, individuals that are referred to as Latino generally all speak Spanish or come from Spanish-speaking countries. The same thing we're looking at for identifying individuals who are Middle Eastern or North African. What they share in common sometimes is a little bit of similar history, but the thing that really is in common is that countries that are Arabic speaking. Ultimately, culture teaches us the ways in which we need to survive in the world. Your first cultural unit is your family. So your family taught you what it is that you consider right, what you consider wrong. They teach you your beliefs, your traditions. All of these sorts of things come from your family unit. And then as we get older, our cultural groups expand to include friends. They expand further as we enter the workplace and the culture of the workplace. We learn different ways of perhaps dressing. We may have to adjust the ways in which we speak. All of these sorts of things about how we behave on a day-to-day and sometimes moment-to-moment basis is affected by our culture. And as we think about even our daily behaviors that affect health are often culturally rooted. So like when you eat, and you consider yourself to have a good diet or a bad diet, what are the specific foods that make up your diet? Those vary considerably from person to person, but oftentimes it's not something that's at the top of our mind because who's thinking about what vegetables do you usually eat, right? And so when we go to perhaps talk with individuals about dietary changes that are necessary, or eliminating diet at the end of life, it becomes very challenging because there can be such differences in how people approach what is considered healthy food and how we transmit that we care to other individuals and what are the behaviors that looks like when you're showing someone that you care for them. And interestingly, with something like food, even though the specifics, even something that you think is universal, like the soup that you give somebody when they're sick, is vastly different between cultural groups, even amongst individuals who belong to maybe similar cultural groups will have wide variations of how they put together like the particular soup that you give when you're sick. So even something that many of us may identify with as chicken noodle soup, talk to a few people and find out if they make chicken noodle soup from scratch. You're like, where does it come from? You'd be surprised at the variation. Some people love Campbell's and do it from a can. Some people would never give that to their sick family member, and it has to be from scratch and made from a whole chicken using the bones. You know, and what vegetables and seasonings and spices do you add? So even something that you might think is perhaps universal often has wide cultural differences and variations in how people apply it and use it in their lives. And so again, as we think about how to provide culturally responsive care, it's of critical importance to remember that every single one of us belongs to a cultural group. And unfortunately, I think that that's one of the things that often gets missed in these conversations about culture and differences is it's easy to think about culture as what other people have. It's what's different than what we identify with. So when we think about culture, we generally think about people who look different from us, who eat different foods from us, and maybe speak a different language than we do, but we don't put ourselves in a cultural group. And so the interesting thing is that for every single one of us, we also bring things to the table, including our own beliefs, biases, values, traditions, and histories that influence the ways in which we communicate, interact, and engage with other people. So the key term here, one or two of them to think about, is culture, are the specific learned behavioral patterns, values, and practices shared by a group. And remember, your first cultural group that each one of you is affiliated or associated with was your family. So whoever it was that raised you, because even think about something simple or seemingly simple as family. That's not consistent. Some of you are raised by two parents of different genders. Some of you are raised by one parent of who knows which gender. Some of you are raised by grandparents. Some of you are raised by people who were not related to you by blood at all. Some of you, have different ways that you were brought up into adulthood. So even something as simple as what we consider family is vastly different and influences of these beliefs, values, and practices, and ultimately the ways in which we're taught to survive in the world. Race and ethnicity are also pretty important. Ethnicity generally are the shared characteristics that individuals have that contribute to their culture. And so when we think about the key races and ethnicities that are here in the United States, we tend to see a few of the same groups. So we, of course, know that we have white individuals. We have Black individuals who also may be referred to as African American. One of the questions that I frequently get is about which term is better and is one more appropriate than the other. And so one of the things that I like to be able to inform folks of is that Black and African American are often used interchangeably, but they don't necessarily mean quite the same thing. When we speak to about African Americans, and there's also some generational differences in what individuals find accepting, because remember, when it comes to how we speak about race and ethnicity, most of the terms that we use are not terms that people chose for themselves. They're terms that other individuals chose for them. And so that's part of the reason that you sometimes see some changing of the terminology as more individuals have some influence, or as we think about how to be more inclusive about how we refer to individuals. And so when we talk about African Americans, African American generally refers to adults in the United States that were born in the United States and the descendants of slaves in the United States. And so the term African American means that there is some African descent, but these are individuals who are American and were born here and were often here for many, many generations as the descendants of slaves usually. The term Black is much more inclusive as it includes individuals who may be of Afro or Caribbean descent. Oftentimes it's more inclusive of individuals who are immigrants. So somebody who may be of a country of Africa, but so they immigrated with their family here. And so we sort of lump them into being Black, but their culture is going to be very different because they don't have the shared experience or that shared history of necessarily being the descendants of slaves here in the United States. And so that's one of the differences, and why in more current times, you'll either see both terms used together or you'll see Black used singularly as a more inclusive term to include all of these other groups of individuals who may not just be Americans, and I'll say all of them are Americans, but may have an immigrant history, a more recent immigrant history. With individuals who come from Spanish-speaking countries, we historically have used the term Hispanic. That has sort of gravitated into Latino as the preferred term. That was one that has been chosen by individuals of Spanish-speaking descent countries. In recent years, some of you have seen X added to the end of Latino, so it is Latinx instead of Latino. There is that, I will say, is a little bit controversial for some folks. The reason that the X was added is that in Spanish language, the O on the end is a masculine term. And so some people have added the X to be more inclusive of individuals who are non-gender conforming. And so the pushback or the controversy, if you will, is because individuals who are Spanish speaking say that that is not a part of their language to have the X on the end, and that the Latino itself is inclusive in that it's not meant to be necessarily masculine and feminine referring to gender, but just to language. And so that's one of the things that you'll see. And so generally when speaking with groups, the preference is to use Latino. But you'll see sometimes, like in research, then they may use a Latin X on the N instead of the O. The other groups we have to be mindful of are we have, of course, Native Americans, which aren't necessarily just here. We also have Pacific Islanders and Alaskan natives, and so and Hawaiian natives. And so those have very different cultures. They're not just, as a term that we used to use, Indian, that people have very different histories and cultures that come from these different spaces, whether they were a part of the mainland in the United States or they were part of one of the island cultures like in Hawaii or, from Alaska and Native Alaskan. Even Asian is such a huge term. I mean, there's such differences. Just think about how that is supposed to include people that are from China, people who are from the Philippines, and then also people who are from India. Very different cultures that we've sort of added one term to and sort of lumped everybody into, that doesn't really give full understanding of all of the different variations between individuals. And so one of the things that I think is important as you are working with different cultural groups is to, number one, ask people how they identify. What race or ethnicity are they? One of the things that I'm finding in some of the research that I'm doing and working with health systems is that we're not great about that. What we tend to do is we make assumptions based upon the ways in which individuals look. And so if we look at this very diverse picture here, this is just some random stock photo. I don't know who these people are. So I apologize if you in the picture. So this guy here on the end, I think that he's kind of racially and ethnically ambiguous. And maybe you might, disagree with me. Maybe he looks like a regular white guy to you. But what if he started speaking with a Spanish accent? He went from being, somebody of maybe European, maybe he was, from Spain, but maybe he is Mexican or Puerto Rican, or what if he was standing there and then all of a sudden his wife shows up and her head is covered? Oh, he's, Arab or Middle Eastern or North African, and I had no idea. So it's really, or perhaps he's biracial and he's just very light-skinned, and there are people who look in this way that have biracial parents. And so the point is that we really can't assume when it comes to race and ethnicity. It's really important to ask questions. And as we're thinking from a policy standpoint of what our intake forms and things look like within organizations, do we have the ability to fully capture how people identify in terms of their race and ethnicity? And do we have the ability to capture if people are biracial? Like, are we making people only choose one? Well, pick the one. Well, are you Black or are you white? How do you choose if you have one parent that is Black and one parent that is white, right? So it's really important to think about these sorts of things and think about how do we embed culturally responsive care all the way down into our policies in the way that we even, one, ask people about how they identify, and then two, record that information so that we're able to reference it at a later time. So as we think about the other thing that's really important is health disparities. Health disparities are preventable differences in disease, burden, injury, violence, or opportunities to achieve optimal health. The key word here being preventable. And so individuals will often have an increased risk for disease, increased risk for diagnosis, access to care, quality of life, even education, simply based on race or ethnicity, and ultimately racism and implicit institutional bias that's in place. So, for example, one of the things that we know is that the United States has a long history of implicit racism in healthcare that came about as a result of Jim Crow. So when we had segregated healthcare systems, you have every older adult that's older than, I think, about 56 now. So around 60. So any older adult that's 60 or older, that is a person of color, is somebody that was not allowed at some point until, they were around, because 65 was when we had the civil rights movement, and it actually wasn't through that. It was through the hospitals were required to desegregate if they wanted Medicare funds. And so that's why the hospitals began to desegregate. But you have many individuals that were not allowed to receive health care in desegregated spaces. And so many individuals have specific stories of being able to feel the impacts of this. And so and one of the things we have to understand is that, again, these are preventable differences that end up affecting care because of health disparities. And so one of the things we want to think about as we're providing care, particularly end-of-life care, is how are we making sure that the care that we're offering is equitable to different groups? So if you're in an area and you're providing information about cognitive changes and dementia, and you know that there's a large Spanish speaking or large Farsi speaking population in your community, do you have resources in that language in that community? So if you're trying to reach that community, then why don't you have things in the language of the community that you're trying to reach? Do you know where individuals of that community may gather health information or what providers that they're going to seek care for? Do you have some understanding of the particular types of issues amongst that community? And so, for example, within the Black community, one of the things that we know is that for dementia diagnoses are very late. Individuals don't get diagnosed early, which means that they may not get some of the preventative treatments early on, and that they often have mixed forms of dementia instead of just Alzheimer's disease. They're much less likely to have a singular diagnosis of Alzheimer's disease. And so what that means is that when we're providing information, we have to be thoughtful about asking just about diagnosis. We have to be asking about symptoms instead. Is this person having some confusion? When they have a bad day, what does their bad day look like? To be able to get to whether or not they may meet some of the qualifying criteria to receive some of the services that are available to them. The big question at the end of the day is, are you culturally competent? And so some of the things that we can consider when we think about cultural competence is, how do you usually solve problems? Do you just make the choice and you're used to people following you because you're in a position of leadership or authority? Or do you subscribe to a democratic process and you're used to being asked or including other people in the problem solving when it's time to solve problems? And that relates down to the family unit. Within different groups, some groups, when you ask them a question about their own personal health needs, they'll make that decision right then, where a lot of individuals, because of their cultural backgrounds, will want to consult with those that are closest to them before they make a decision, particularly older adults who may be reliant upon their children or grandchildren to assist in their care needs. Or they may have somebody that they consider to be an expert in the family. And maybe it's a nursing assistant, maybe it's a physician, maybe it's a nurse, but there's somebody that has some relationship to the healthcare field where they consider, again, this person to be an expert in their family. And so they want to run things by them before they just make a decision. And so how do we support these sort of inclusive environments and encouraging people to consult with these folks, or inviting everyone to the table to begin with? So before having a meeting to talk about end-of-life care, asking, who are the people that usually help you to make decisions, or do you think might help to care for you if you had an issue? When are they available to have this conversation? What do I consider to be signs of respect? One of the ways that communication breaks down very early in the relationship is making assumptions about how individuals prefer to be called. So for example, in a lot of communities, it is considered to have a very casual relationship, and it shows that you're very friendly to use first names of individuals as you're speaking with them. It shows that we're all on the same level and we know each other. To use someone's first name and make a point of saying their first name so that you can say that I've remembered your name and you're important to me. In some cultures, that's not okay, particularly amongst older adults. They are, because of, again, a long history of racism and individuals not being referred to as their first name and being spoken down to, it is of high respect to use some titles in front of their name, to call them Ms. So-and-so or Mr. So-and-so. Or if it's a very casual relationship, what's done in many communities is to add an auntie or an uncle in front of that name of someone who may not even be related, as a sign of respect for that individual. And so one of the things that you'll notice today is I'm not going through to tell you, when you work with Black folks, do this. When you work with Asian folks, do this, because there's so many variances and differences and different cultural groups that people subscribe to. What's most important is to understand that you have to communicate with people and with individuals and with families to understand what's important to them. And thinking about more globally and generally, how are we embedding these practices that value the unique contributions of individuals to their own health in the way that we're delivering service and the way that we're providing care? How do we put people back in charge of their care instead of us, running their care for them, which we're still gonna, maybe have some expertise in being able to direct care, but we're not going to get very far, particularly with increasing the diversity in our groups, because that's just not the way in which many groups view us. Many groups view us as consultants in care, and not necessarily as those with the authority. They ultimately are going to make the final decision. And so as you kind of look through this list, these are just a lot of different things that, again, are culturally rooted, that we don't necessarily associate with culture, even down to time. That's something that is rooted in healthcare practice, right? We're used to working in shifts within healthcare because we have to operate on a 24-hour basis. And so what that means is it's really important to us as healthcare providers to be timely. And so we may not have very much, it can be difficult to sometimes work with individuals who don't have that same sort of timeliness about things. And again, that's healthcare culture. And so how flexible are we with that when we are wanting to, for example, schedule meetings to do like a community forum? We do a community forum at times that are convenient to us, which are the times that we're working from 9 to 5. But if that's when the rest of our community is also working, we're not engaging maybe some of the people that we need to. Maybe we need to move the time to the weekend and meet in the afternoon when people have had the opportunity to, leisurely get up and then join our nowadays Zoom call, to engage. Back when we're able to meet in person again, people need a little bit of incentive to get together, to engage, to talk about things, because it's exhausting being a caregiver or providing care at the end of life. No matter how much we feel like it's a blessing to be able to do that, or to feel committed in doing that, it can still be ultimately very exhausting for individuals. And so we need to have some incentives, like, are we feeding people? And then if we're feeding people, are we feeding folks in the community things that they would actually eat? And who did you ask when it came time to do that? Are you choosing locations that are easily accessible for individuals, or at parts of communities that people might regularly frequent? So for example, here in the Detroit area, our local Alzheimer's Association, as well as some of our, we have a Healthier Black Elders group that is part of Wayne State University. And then we also have the Michigan Alzheimer's Disease Center has some outreach. And all of these groups meet at places like senior centers, in churches, in the local community. We're in the city. We're meeting in the locations where individuals would typically meet or gather together, and we bring the education, the information, and the resources to them where they are, without the expectation that they come and find us where we are. I mean, that makes it a lot easier for individuals to engage. Is there still work? Absolutely. But it certainly puts forth that effort of, again, going to where people are. Our ways of communicating, again, are culturally rooted. How we communicate, you'll notice differences. Even there's some research about birth order. So when you think about either birth order or your family size, how many of you come from very large families where you had at least, 2 other siblings? So there's 3 kids or more in the family. And then how many of you come from a family in which you were an only child? Now think about how you had dinner at the table as, parts of these families. Individuals that were an only child probably got to tell your parent about how your whole day went at school, anything that you wanted to talk about. You had the full undivided attention. You weren't used to being interrupted, because that's how you learned to communicate in the way in which you were raised. Individuals from large families had the exact polar opposite sort of dinner experience. There's multiple people talking all of the time. The only way you can get a word in edgewise half the time is to interrupt somebody, or by the time they get to you, you'll forget what you were saying. And it's very loud in many instances. It's not quiet, just because of the sheer number of people. And so these ways of communicating stick with people. So when you have people that may be more readily going to be interrupting of a conversation to quickly ask you a question, and then maybe move on, and they don't think anything of it. That's why it's culture rooted. And I know some people find that highly irritating when they're talking with someone and someone comes to interrupt them to say something instead of waiting until they're finished, and that's why. It's not necessarily that they're being rude. It's just a very different way of communicating. And for this particular slide, what I think is important, this is the scale, or this work was done by Albert Morabian, that talks about when we communicate, how much of our communication comes from our actual words. You can see here, only 7% of what we say tends to make a difference when we are communicating from person to person. The vast, I won't say the vast, but a little bit more than half of what we communicate is communicated through our body language. And then the next significant part is through our tone of voice. And so this is part of the reason that when individuals are providing care for folks with cognitive impairments, that you'll have some staff that have a really horrible time. And it seems to be like every time it's the same person that's having an issue, and you're having a hard time being able to put your finger on what's wrong. They're not necessarily doing anything wrong, but people just don't like them, meaning the patients just don't like them. Oftentimes it's their tone of voice or their body language when they're working with folks. And that can be something that, is challenging to be able to teach and model sometimes. And tone of voice is something that people still pick up on and differentiate in with dementia, which is why you'll see how their receptiveness to different staff will change based upon the staff person's ability to effectively use body language and tone of voice to communicate. The National Institutes of Health, we have national standards for culturally and linguistically appropriate services in health and healthcare. They're called the class standards. And so for those of you who are looking to develop some policies within your organization or want to take this a step further, the class standards list out, I think there's 13 different standards about the ways in which we provide care within health organizations and what the standards should be. And these are government documents and they've been around for a long time. And essentially what it says is that we're responsible for providing effective, equitable, and understandable care that's also respectful and responsive to the diverse cultural and health beliefs and practices and preferred languages, as well as health literacy and other communication needs. And so essentially these class standards sort of outline the different things that we need to be paying attention to within our organizations, which some of them we mentioned, like making sure that you have documents available in the languages of the communities that you're serving. Also thinking about persons with disabilities. Do you have interpreters available? Are you making sure that when you're offering services that they're accessible by people? Like, are you doing captioning? So that the deaf community is able to participate, or asking people what sorts of accommodations that they need so that they can effectively communicate and engage in whatever it is that you're trying to do. And then from a health literacy standpoint, do we have an understanding of what people know about disease progression? And so as we're talking about dementia within communities, how do people talk about dementia and end of life care? And it's really fascinating. Personally, I always talk about my grandmother, one in particular who had Alzheimer's disease, and she died from Alzheimer's disease. Ultimately, we were able to keep her at home until she was 93 with the assistance of family caregivers, right? We had two young cousins of mine that got voluntold. So, you have some young people that maybe aren't doing anything in particular, and they were asked and told at the same time to go to grandma's house to keep an eye on her, is what, they were asked to do, but they weren't provided any particular education on what dementia was, what sorts of behaviors to pay attention to, or even what they were supposed to be watching, to be completely honest with you. And so as my grandmother's dementia changed, some of the behaviors, even the ways in which we spoke about her behaviors, is interesting. We never really spoke about her having dementia at any given point in time. We talked about her having good days and bad days. And we talked about her behaviors, like, well, grandma goes in the bathroom and spends a lot of time in there. And so you need to go knock on the door and then open it if she doesn't open it, and remind her to come out, or make sure that she doesn't go outside. And so we spoke about her behaviors, or would say like, oh, she's having a bad day. Don't call today. You'll get your feelings hurt today, but there was never that she has dementia. In fact, to this day, I recently was talking, she passed last year, and I was talking with my mother about her and her Alzheimer's diagnosis. And my mother was like, wait, let me think about it. Did she have Alzheimer's? I'm like, yeah, she did, but it's just not something that is necessarily spoken about in the way that you think that it would be. And it's the exact same thing, even with other conditions that can affect cognition, like Parkinson's, disease. My other grandmother died from Parkinson's and had Parkinson's dementia at the time of her death. We've never had a conversation about either the Parkinson's really or her dementia. Most of her care-related activities were related to getting her needs met. And that grandmother was actually on hospice care. And so the focus of hospice care was really being able to keep her at home for as long as possible, and understanding what services allowed that to happen. And then it was followed by the extra support that was provided once she went into a nursing home, where they were able, of course, to continue to provide care for her. So again, and thinking about health literacy, how do communities think about these health conditions that we would like to treat and support? And how are the different ways that we can communicate differently? Like, how do we re-message what we're saying so that people can get the access to the services that are available to them in their communities? When we're providing culturally congruent care, these are some of the main things that we want to think about. It's these main concepts here. So appreciation means that you acknowledge the values that people have. What are the things that are most important for them in care? So in talking with families at end of life, ask them what's most important to you. And so if somebody is saying that like the most important thing to them is that their loved one continues to eat, and we know that that's not a realistic end of life care goal, that's where we have to move into some of these other areas. And so accommodation means we adjust care as possible to be able to incorporate the values and beliefs that are important to individuals. When we can't adjust care, so at end of life, we know that there comes a particular space for a person with dementia where they just aren't eating and it's not safe for them to continue to eat. We have to give an explanation as to why. Why is it that you can't keep like trying to give this person soup at this particular point in time? And then this next part is what's often missed, this negotiation. How do we negotiate or put something else in place so that it still fulfills that need for that person to be engaged in care? So if we take away the soup that they want to feed that person, that might cause them to develop aspiration pneumonia, because it's a natural process of dementia care that at some point that person's going to stop eating. What other task can we give them that demonstrates love and caring and support? Can we teach them how to do oral care and how to, make sure that their lips are nice and coated, and that we, clean out their mouth well, and perhaps doing some skin care and showing them how to do a massage or some other ways to communicate love and affection that doesn't involve food, but something that can be regular and consistent in the way that you might try to get somebody to eat. Another way of thinking about this is through the LEARN acronym, which just means that you want to listen to what the people are that you're working with have to say about their care experiences. You want to explain things. I can't emphasize this enough. As a hospice nurse, you would think that by the time individuals are at an end-stage disease, that they have a really good understanding of what's happening to them. And then honestly, it just doesn't necessarily connect for many individuals, and they have to keep hearing what's going on and what to anticipate. That both normalizes the change in disease process and the decline that they're experiencing, and it helps to get them to think about the changes that are happening, right? We want to acknowledge individuals. We want to acknowledge their beliefs and their values. I can't tell you the number of people that were open with me as a hospice nurse about the different sorts of home remedies that they were using, or even drug use that was taking place, because of acknowledging how challenging it is that people go back to the ways in which they're used to coping. So if you used to drink when things got tough and you were stressed out, you're going to go back to drinking when things get tough and you get stressed out, if you don't have some good supports in place. And so being able to acknowledge that and have a safe space for people to communicate exactly where they are is important. And teaching our staff and clinicians to be able to think about what their own biases might be, so that they are able to effectively listen and to acknowledge when they're engaging with individuals. We want to be able to recommend appropriate treatments that are in alignment with people's beliefs and values, because otherwise it makes no difference whatsoever of what we're saying. So for example, with diet, if you're trying to, for example, somebody is constipated and you're trying to recommend some particular foods for that person to eat in addition to some maybe medications, it's not helpful to make recommendations of stuff that they're never going to eat or that aren't a typical part of their diet. And so that goes back to acknowledging and listening to the sorts of things that they eat, so that we can make, recommendations that fall in alignment with stuff they would usually do. And then again, we negotiate where we maybe really want to push people to do some things differently. So ultimately, with culturally responsive care, it means that we want to learn protocols, recognize family patterns, address individuals as appropriate, really be thoughtful about the body language and gestures that we're using, as well as what we see other people using. Think about how we're conveying or trying to convey respect and interest. Try to be unhurried, which can be really challenging depending upon what the situation is. And then to make sure that we're providing health literacy in ways that are understandable. Really try hard to avoid medical jargon when we're talking with individuals. Use the terms that they're using, even something simple as pain. And doing a pain assessment, I've experienced that individuals that clearly had severe pain, as evidenced by the way that they were walking and rubbing body parts, because for them it was it felt like a burning sensation. They didn't call it pain. It felt more like neuropathy. And so when you ask them if they had pain, they say, no, I don't have any pain. But then when you kind of switch it up and say, well, are you uncomfortable? Then they're able to respond, and we can get accurate information that then allowed us to provide better care. So think about the language that we're using to make sure that our language, when possible, is modeling the language of the individuals that we're communicating with. And then keep in mind that a lot of words may have cultural meaning. And that gets to this cultural humility, is that, you know, when we're learning about culture, it's really a lifelong process of both self-reflection, understanding the things that are important, your values, your traditions, your beliefs, your biases, all of us have them. And then being able to critique ourselves and thinking about how our beliefs and values influence, you know, because I think that's the first problem, when we don't recognize that it influences how we communicate, interact, and engage with other people. Then we're able to do it more effectively when we can be honest about how our beliefs and values change the ways in which we engage with others. And so it's a lifelong process, because we're all gonna continue to make mistakes. We have to learn and be humble about this learning process, and be willing to jump back in to do the work to continue to communicate well. That's ultimately what it comes down to, is how do we communicate well with people who are different from us. The other thing I wanted to make mention of with at end of life care, and particularly with dementia care, is that mourning is still taking place. People have anticipatory grief as they look at their loved one changing. This is the same across cultures. What's different is how they work through this grieving process of accepting that the person that they love is likely dying, dealing with the pain of the loss, trying to figure out how they're going to survive in this environment. And that means different things for different folks. I mean, what does it mean when you have people living in a house of somebody who's dying, and they're not sure what's going to happen with that house and where they're going to live after that person goes? So there's just a lot of different factors that can play a role in this mourning, you know, process. And then that last task of withdrawing emotional energy and reinvesting it in other relationships, we sometimes see this as we're trying to provide care, where it seems like people just maybe aren't that interested, or they might be hard of, you know, to get a hold of. And it's just really them working through their mourning and grieving of loss, and attempting to reintegrate themselves into society, and thinking about what it means to live without this person. And also helping other family members to understand that. Again, culture influences the grief process. That means their personality, the ways that people were taught to cope, their religious beliefs, the support. Sometimes gender influences that, right? Because there's gender roles, our societal roles, and the ways in which we were taught that it's okay to grieve. So maybe some men were taught that it's not okay to cry or to engage in particular ways, which then affects their grieving. And then, of course, substance abuse and a history of mental illness can really make a difference with how people will engage with, you know, community health providers and agencies that are interested in working with families to take some of the load off during this process, and to provide supportive services. So many of you are familiar with Elizabeth Kubler-Ross stages of grief. People can be anywhere in this space. And so depending upon where they are in this space, it can make it challenging to engage with them about providing care. Remember that a lot of different people are engaged in the caregiving process. This is some of my own work and working with Black caregivers of persons with dementia. We see that the vast majority of people were taking care of their parents, about 20 individuals in this particular study, so about 36%. And then spouses. And so as we think about how do we provide the appropriate messaging to people, keep in mind that it's not just immediate, you know, spouses that we're talking to. A lot of times it will be children in many instances. And sometimes it's even, you know, ex-spouses that we're engaged with. And so what does that mean in terms of how we engage with them? The last thing here really is to think about advanced directives and talking with folks about advanced directives well before they need to use them, particularly in Black, Latino, Asian, and other groups of color. There's a lot of low levels of trust in the healthcare system due to past experiences, as we talked about earlier, with health disparities. There's been some poor access to medical care, as well as a lack of knowledge just on how to complete advanced directives. Some of the fear that, you know, if you give up, people have a belief that if they give up their right to their medical needs, somebody can have things done to them, and not understanding that advanced directives go into place when they can't make decisions for themselves. And also that the person that is maybe going to help make decisions for them medically isn't necessarily the same person that might make decisions for them financially. So, of course, I know many of you are already familiar with this. If individuals and families are experiencing end-stage dementia care, regardless of the cultural group that they may consider themselves to be a part of, one of the things that we can promote is the services that are available either through hospice or sometimes within comfort cares within organizations, and how it can take the burden of care off. And these are some of the main things to pay attention to. If we're seeing that individuals are having repeat hospitalizations, they have pressure ulcers or wounds that aren't healing, the family wants comfort care. And one of the things I think that I talk frequently with patients and families about is if the physician feels like, you know, nothing more can be done. And really a different way of saying that is, would your doctor be surprised if this person were to die or pass away in the next 6 months? And a lot of people, you know, when they think about that and even think about it themselves, like they would be upset, but they really wouldn't be surprised. That's usually a good indicator that hospice might be appropriate for that individual. So in summary, you really want to recognize that culture influences all aspects of life, particularly during illness. Really take some time to get to know your own values and beliefs, get some basic knowledge about common cultures in your community. So each community is going to be different. Know the people who are a part of your community. You can only do that by being engaged in the community. And granted, that looks different during these COVID times, but the folks in the community really haven't changed significantly. And so you can still find out who's a part of your community to reach those groups. Culturally sensitive care is best delivered through interdisciplinary approach. So it's not a job for just the social worker. Everybody has a piece here. And then it's most important to get information based on individual assessment and not just making assumptions. This is my grandma, Lula Brown. She, you know, and so thank you for your participation and engagement. Please feel free. I'm going to take some time to answer questions now, but if you have other sorts of questions or looking for information, do feel free to email me. You can also follow me or contact me through Twitter.
Excellent. Thank you so much, Dr. Robinson Lane. That was amazing. So much great information. And I will share, again, if you guys have any questions about anything, please put them in the Q&A or the chat. I will share, we do have a couple of questions. One of them, how does the family seeking support for the individual who has dementia ask for the services that are offered if the symptoms haven't been classified as such? What's the starting point and what conversation with caregivers can you have?
So if a person hasn't yet been diagnosed with dementia, they still may qualify for services based upon their symptoms that they're experiencing. The main thing is it starts with a conversation with your physician. Is what is helpful is to talk with the physician about what's going on. The other thing or amazing resource that a lot of people aren't aware of is the Area Agency on Aging. The Area Agency on Aging, if you call and look up your number for your local area, has a wealth of information about services that are available to older adults in general. And so many of those are also based on mobility. Like, for example, maybe somebody isn't ready for hospice care, but they're not preparing meals for themselves. They can maybe get them connected with Meals on Wheels, or maybe they can get them connected with congregate meals in the area that even may have transportation that will come and pick them up. You know, perhaps there's adult daycare. So one of the biggest problems I see in for care in older adults is that as people age with disability or develop changes in functional status as they get older, they don't consider themselves to be disabled. And so they end up being isolated from like all of the services that are available for disabled people. And so I'd say those are the two places to start, is with your local area agency on aging, and then also with the physician. A lot of people also don't know that if you think that somebody, so like for dementia care, basically in order to qualify for dementia care, if somebody's on hospice, you have to be bed bound. And so at that point, you can contact the hospice directly, and they can work with you and your physician to see whether or not they qualify for services. So even though the family may not acknowledge necessarily that that person has dementia per se, you still may be able to get them connected with services and have that conversation with the family, as well as, you know, it's a conversation with the doctor about what their status is and if they're likely to you know, if they have a good health trajectory. If the health trajectory isn't well, they usually can be supported on services in some ways.
Thank you. Yeah, someone was just commenting that their husband was hospitalized, and if we didn't go to the ER, would never have known that he had pneumonia. So it's also a matter of the folks who have it, right? Like you were mentioning, I'm not in pain, but I do have a burning sensation, right? So it's a language thing, right? And also, as we know, no matter what culture, you know, men are raised to be tough guys sometimes, and they don't want to share any of the pain or any of the.
And the other thing to keep in mind, because maybe that's a little bit closer related to, you know, some of the things that are happening with COVID in particular, is that with conditions like pneumonia and COVID in particular, you're not getting enough oxygen. If you're not getting enough oxygen, you're not getting enough oxygen to your brain, which causes some confusion, which affects your decision making. So if you take anything other than the culture stuff away today, the other thing you have to remember is that when it comes to pneumonia or COVID, and you feel like that person isn't breathing well or doing well, and you think they need to go, you need to make them, because they aren't thinking optimally. And sometimes we are hesitant if we know that the usual personality of the person that, you know, we're talking with maybe is a little cantankerous and they probably wouldn't want to go. You should push it, and everybody should have a pulse oximeter at home. So that you can look at oxygen levels. You can order those. I hate to, you know, promote Amazon, but you can get them on Amazon for under $25. But everybody should have one at home. And if you have babies or grandbabies, you should have a pediatric one, because the adult one doesn't work on little fingers. So you need to have two. But that has really been life-saving for individuals to know when it's time to go to the emergency room, because the numbers on there, your oxygen saturation needs to be above 90%. And so, you know, when you're sick, you feel like you're dying in general oftentimes. And so you need to know when you really are maybe dying and need to get in there.
Absolutely. We have a quick question. Do you know, is culturally sensitive training a regular part of nursing school?
I think that nursing schools are working on it. I can say like yes and no. So I think I'll say that nursing schools are working on it. I know, like, you know, I'm with the University of Michigan. We're rethinking how we add that into our curriculum. I'm currently editing a textbook chapter on culture, and I'm completely revising it because it's maybe not as accurate as I would like it to be. So I think that nursing schools are trying, and they have engaged it, but the ways in which they've engaged it doesn't necessarily include this model of people self-identifying a culture of their own. Oftentimes the way that it has been approached is by trying to teach about specific like racial and ethnic groups and maybe the health problems that they may experience, which doesn't allow people to see themselves as part of a cultural group and how they may contribute to communication and influence in healthcare.
There are some other questions about dealing with dementia, end of life. If you want to chat a little bit about some activities, or not necessarily activities, but ways to connect. If we could share a couple of those, if you don't mind, Dr. Robinson.
Connecting about end of life?
Yeah, while we're going through end of life, connect with the folks who are passing.
Oh, so one of the things I think is the thing that I think is most important that people know is your hearing is the very last thing to go when you're dying. Of all of your senses, your hearing goes last. And so the most important way is to continue talking with people. And I know that in these COVID times, it's not easy to do so, but even something as simple as like, if you're not able to, most of the facilities have, they keep changing depending upon like how bad COVID is in your particular area. But for most of the facilities, they are allowing one visitor when people are on hospice or the person is dying to go and visit, so they can still continue. But if you like an extended family member, that's just not an option. You can have the staff go and bring in either the phone and put it on speakerphone where you can continue to talk with that person. If you have people that are just even older adults that you want to continue to engage with and maybe not be the greatest with technology, and maybe you have the funds to get like an iPad or even a cell phone that has the apps on it for you to call them, buy it, set it up for them completely, and then send it to them so they don't have to do anything. They just click on the buttons they need to. Google Voice and the Amazon Voice, I don't know the names of these things, but like these sorts of devices, a lot of folks have been using very effectively with people with cognitive impairment that are still able to talk, because they can call out the name or say, call John, or, you know, whoever, and it is programmed with that information so that they can easily communicate. Still send cards. But I think if they like listening to music, music really makes a huge difference for folks. But know what the music was that they listened to, like, you know, maybe when they were in their 20s or so. So thinking about how old they are, and then pulling like maybe the popular music from that particular time frame. People often find that very enjoyable. My grandmother was very religious, and so they often played some of the religious music that she liked for her. And she that really was comforting to her.
Excellent. And thinking about foods, right? Smells of home cooking and certain stores or movies, right? Just listening
Absolutely.
to Cadence's voices, that kind of thing. Another question, kind of professional wise, in many medical programs, do you see that they teach in depth about the history of medical mistrust for people of color?
I don't think so. I mean, to be completely honest with you, like, I think that it's only been in recent years that we really are coming to a wide cultural understanding of really the role of implicit racism and its effect on health. For whatever reason, like, it's just, I think it's odd for me that there's such a disconnect from that. So even when I say, like, you know, about, like, you know, the segregated healthcare system, like, people, I think, know of that and they heard about it, but I think it's somehow disconnected from the experiences that people actually have. Like, people are surprised when Chris Rock says that, like, you know, his mother doesn't like watching, you know, movies about, you know, old times because, you know, they had to go to the veterinarian to get their teeth, you know, taken care of because of racism. Or, you know, even my own grandmother, who lost a set of twins while she was pregnant because the hospital closest or near her was a segregated hospital and refused to see her. And so, you know, we don't necessarily sit and accumulate all of these different stories about how care may have been different. But it certainly has been an embedded part of many people's history. And so even for folks who don't necessarily have a story and maybe haven't experienced, you know, you can think of racism as a stressor. So they haven't been stressed from that because maybe they didn't necessarily experience it directly. But the effects of not having equal and access care has certainly made a difference. And so I think that that work certainly needs to continue, and not using it as an excuse for not engaging people. Because I think in my work with older adults, and particularly with Black older adults, is where much of my work is, there's also a perception like people want and they're willing to get care. They want to be heard and listened to, but they also are very objective about the care that they're receiving. So they want to get care, but they don't necessarily want the answer to be to take a pill. So it's not that they don't trust you or what they're saying. It's just that I don't want a pill that's going to maybe cause some other problems, and they want more information. Many of these groups, you know, now with Google out here especially, they'll come and ask you, but if they're asking you the question, it's probably a very, very high likely chance that they've already Googled it and they want to know what you have to say. And so if you're saying something completely different from what the internet says, you know, that maybe adds to the mistrust.
Thank you so much, Dr. Robinson Lane. We have a bunch of questions that we have addressed on there, and then we've also taken some information that we're going to reach out to some of you folks and send some of you to the helpline as well. We appreciate so much your time and being with us, and grateful that you spent some time and opened our eyes to a lot. We learned so much, absolutely so much today. And there are some questions also about wanting your PowerPoint and certain pie charts. Some professionals are really interested in some of that, so maybe we can get some of that from you and pass it on to our folks here.
Sure.
I would like to bring back Chris.
Joining us.
Thank you. I would like to bring back Chris Sortwell to share a few things at the end here.
Hello, what a great program, and thank you all for joining us today, and thank you, Kristen. We will be sending out a link to the recording of today's program, so hopefully that'll help everyone. Also, please watch for updates on our association website, www.alz.org, and our Facebook page for the Connecticut chapter regarding future programs, including educational seminars and special guest speakers. Also, keep a lookout for community forums near you. Now, these forums allow us to pinpoint the needs of local communities by gathering information and feedback directly from those who are attending. So if you're interested and you want to participate in this, again, check out our website, or you can contact us at our 24/7 helpline. But if you want to have one in your community and you do not see one scheduled, again, contact us and we would be glad to set one up. And if you're interested in learning more about the association's continued diversity initiative or any of our other wonderful supports and services, please feel free to contact us. Again, the 24/7 helpline number is 800-272-3900. And I once again want to thank Florence Johnson and Sheria Robinson Lane for dedicating their time to us today. Once again, just an amazing program. And from the association, we want to thank everyone who took the time out of their busy schedules to join us here today. So thank you very much. Be safe and enjoy the rest of your day.